Hi everybody. Today we're going to talk about ultrasound imaging or sonography. So ultrasound imaging can also be called ultrasound scanning or sonography. The terms are kind of used interchangeably. So with ultrasound, it's a relatively inexpensive, fast, and a radiation-free imaging modality. So ultrasound is actually very good for non-invasively imaging and diagnosing a number of organs and conditions without, again, using X-ray radiation. So it can visualize real-time images where you can see actual movement within the organs or blood vessels, the fetus, or tendons. This is an image of what an ultrasound suite or room would look like. So you've got a bed where the patient can lay down, patient's laying there, the machine here, and the screen, and then obviously you have the sonography technologist who's explaining what she sees on the image to the patient, which is very common. So how does sonography work? Well, in the 1960s, the principle of sonar was applied to medical diagnostic imaging for the first time. That's not when sonography was developed. It was originally developed by the Defense Department during World War II. Sorry. However, we didn't use it in medical imaging until 1960. So the ultrasound process involves placing a device called a transducer against the skin of the patient in the area of interest, so wherever we're trying to scan. So the transducer has what's called piezoelectric crystals inside of it. So what happens is there's actually an electrical current that's applied to the transducer, or the crystals inside. And then what happens is the crystals will vibrate or change shape. And then as they do that, they'll produce sound waves. So those sound waves will travel out of the transducer, and then they receive the echo as they bounce back off of the organs. So the transducer kind of acts as a transmitter and a receiver. It's transmitting those sound waves out, they go through the body, they bounce off the organs, and then they come back, and the transducer receives those images again. So the ultrasound transducer produces a stream of inaudible high-frequency sound waves which penetrate into the body, bounce off those organs inside, then the transducer detects those sound waves as they bounce off or echo back from the internal structures. And then what it does is it contours the shape of the organs. So different tissues inside of the body are going to reflect those sound waves differently, which can cause kind of like a signature, which can be measured and then turned into the images that we see for ultrasound. So the computers that we use, and the reconstructive software takes those sound waves that have bounced back and turns them into the pictures. We use a conductive gel in ultrasound. It has to be used to remove the air between the transducer and the patient's skin. If we don't use that gel, one, that gel is going to help produce a better quality image, but if we don't use it, if there's no gel, then the air from the ultrasound waves will be reflected away from the patient's body instead of penetrating through the skin. It also helps slide the transducer a little bit easier on the patient. It would be a little bit more difficult to move without that gel. Most facilities, they have a gel warmer with the machine, which helps warm the gel up so it's a little bit more comfortable for the patient when they squeeze it on. If we use cold gel, it's a little startling sometimes. If you've ever had an ultrasound, you know I've had both cold and warm gel, and I definitely would prefer having warm gel. So for our patient's comfort, if we have the option to warm up the gel, that is the best practice. So these are some of the different transducers that we use. Transducers come in many different shapes and sizes. Some are placed over or on the body to view the internal organs, and others are designed to be inserted into an opening, such as the vagina or the rectum, so they can get a little bit closer to the anatomy. Especially in early pregnancies, if the fetus is like 6 weeks or so, sometimes it's hard to see them from scanning externally. So what they'll do is what we call a transvaginal ultrasound. So they'll insert the probe into the vagina. That way they can get a little bit closer to the anatomy and they can see the fetus more clearly. So the footprint on the transducer is what's touching the skin. Um, there's larger footprints, and then there have smaller footprints, right? So you can kind of see the difference there. The larger footprint is more expansive and has a bigger viewing area. And the smaller footprint, it obviously has a smaller viewing area, but it's good for in-between things such as ribs, the fontanelle on the skull, or cardiac ultrasound. The acoustic lens on the transducers helps focus these emitted sound waves, so it's directing them into the body instead of kind of bouncing off. So when the transducer is placed against the skin, the sound waves come out and it hears its own echo, that reflected sound that's coming back. It produces the white image. So if the transducer doesn't hear any sound, then it's black. Usually that's fluid. Remember, on x-rays, black was air, but on ultrasound, black is fluid. So a lot of times it could be a cyst or a tumor. Those things are going to be dark on the image. Transducers also come in different frequencies. So a high frequency transducer is going to have less penetration, but it'll have greater resolution. So the sound waves aren't going to go down as far, they're not going to penetrate as far into the body, but because they're not traveling as far, it's going to give you a better quality image. So we use those on more superficial structures like the thyroid, breasts, and testicles. Lower frequency transducers, they're going to penetrate deeper into the body. But with that deeper penetration comes less resolution, so we're not going to get as good quality of images. But we use those on things like the abdomen, gallbladder, and the pelvis. So here's a few of the different types of transducers as well. So we have linear transducers, curved or curved linear, and then skinny phase transducers. So the linear transducer, and you can kind of see how the sound waves come out. See how these are just coming straight out, where these ones curve a little bit, and these ones are going to phase out even more. So the linear transducers have a high frequency, but they don't go very far. Remember, they have that low depth. So like I said, we use those for breast, thyroid, testes, and nerves. You will see a large surface area with that linear scanner, with that linear transducer. The curved or curved linear is a balanced frequency. So this one has a high depth. We use this a lot for abdominal ultrasound, so we can get far down in to see those abdominal organs. The skinny phased is a low frequency, but it's high depth, so it can go far into the body. Think of it like a telephoto lens. You know, we can zoom in really far to see further away. This one has a small footprint, which again I said in the last slide, but it makes it really good for going in between ribs. So this is used a lot for cardiac ultrasound. It's not really ideal for abdominal ultrasound. And again, here's kind of another one and what the images looks like. So in a linear transducer, you're going to get kind of this rectangle image. The curved, you can kind of see how the image curves out here. Hopefully that quality is pretty good. They use this again for abdominal, cardiac, lung, fast, and rush. So fast and rush, if you're wondering, rush stands for rapid ultrasound for shock and hypertension. And FAST stands for focused assessment with sonography in trauma. So a lot of times, like if they'll use those for abdominal trauma to see if there's any free fluid or lacerations. And then the phased, again, they use this for cardiac. You can see here, it's got the smaller footprint up at the top, and then it fans out. You can kind of see them here. I can't remember, I'll show you on the next slide, but see these little notches on each side of the probe here? Those are probe markers, and you can see it a little bit more on the next slide. They're really important for orientation. So this one here you can kind of see has a physically, you know, you're able to feel it. It's a mark on the side. Some of them are just like a little green dot or some other kind of indication. But what that does is it shows you where the orientation on this transducer is going to relate to the patient. So every probe is going to have one. And it's really important that you use those markers. So the probe marker should always face either the patient's right side or the patient's head. Then that way you will always know on the image what you're looking at. Every image is also going to have a relating mark on the screen. So right here, see, it shows this green dot, and then you've got the green dot here. So what this is saying is this is the superior portion of the patient, and this is the inferior portion of the patient. So this point is this part is pointing towards the head, and this is towards the feet, just like the transducer is on the patient. So orientation, like I said, of that probe is very important from the beginning. Otherwise, you're going to be all screwed up and backwards and not know exactly what anatomy you're looking at and where it's going. These are a couple different types of ultrasound machines. So this one here is the standard one that you'll see at hospitals. There's a lot of variation that comes with the machines, but they all have very similar features. So these can be moved, they're on wheels, you see, so they can be moved around in the room and they can be moved around in the hospital. They can be taken to the emergency room, they can be taken up to the floor, right to the patient's room, so they can help do scans or help with procedures right in the patient's room. This is more of a portable system, so this transducer can hook right into an iPad. Some of them have their own viewing devices. But the handheld is kind of nice because it's portable. It's very portable, right? I mean, doctors can use them and have their own for quick viewing. The difference is they're not as high resolution. So you're not going to get as good of a quality image out of this. But they are great for quick little scans, emergent situations where you just need to see something real quick. They're even great for military, for taking out right out on the battlefield. I mean, somewhere where you're not going to have access to a standard ultrasound machine. But as of right now, these are not going to replace a standard ultrasound machine. These are some of the different ultrasound machines control panels. So knowing how to use these different buttons is referred to as Knobology. So there's a lot of different buttons on here and it can be overwhelming at first. I mean, the keyboard itself is simply just to be able to type information. Some of the more important things you've got here on each of the machines, what we call a trackball. So the trackball is kind of just acts as your mouse to scroll around the screen and move things. You're also going to have a probe selection. So here on this machine, they've got a couple different probes. The same here, 1, 2, there are 3 different probes that they mainly use. You've also got the gel on this one, place to hold the gel. You're also going to have, let's see where it is on this one. Brightness, which is usually a B. Can't see if it's on there or not. Sorry, old eyes. So B will stand for the brightness, where you can change the brightness on the image. There's M, which is the motion mode. So that's used for graphing movement on the image. CF is color flow Doppler, so it's going to show the direction of the flow of blood. You've got pulse wave Doppler, which is going to measure the blood cells. You've got gain down here, so it controls how dark or light an image is. It can also measure the strength of the ultrasound signal, and gain can amplify all of the signals as well. So if gain is too high on an image, the image is going to be white, and if it's too low, the image is going to be more black. So the best gain is going to show a variation of like white, grays, and black images. These up here, the TGC, are the time gain control. These account for tissue attenuation, and it reduces the impact of the attenuation. So what you can actually do with these is, again, kind of change the bright and darkness on an image, and it controls it from the top to the bottom of the screen when you're looking at it. So if the bottom's really dark, you can lighten it up. If the top's too light, you can darken it up. So you can adjust your image brightness and darkness here on varying levels, not just one image, not just the image as a whole. You can change all of it individually. Depth is going to adjust how many centimeters depth the image is, and most images as well will have the depth listed right on it, so you know how many centimeters it is. So all the machines are different, but they all have very similar controls on them. So once you get used to using one machine, it's going to be fairly easy to transition to a different machine. The buttons may be in different spots, they may have a few additional features here and there, but overall it's going to be very similar. These are some of the different planes that we use in sonography. So we use the coronal plane coming in from the side, right? The coronal plane divides the body into anterior and posterior portions. We use the transverse plane, which divides the body into superior and inferior portions. And then we also use the longitudinal or sagittal plane, which divides the body into right and left halves. So the plane that we use is going to depend on the anatomy that we're imaging. So here's some different scans here. Sorry, I want to see if I can open this up just a little bit. Move that, it's hard to see. Okay, so the sagittal scan is the anterior approach. So this is kind of how the transducer sits on the skin, and then how it's going to fan out and how you're going to see the image on the screen. So again, that transducer, remember, it has a mark on it, so we're going to make sure that that mark is pointing towards the head, and then this portion of the image, when we look at the screen, is going to be the superior portion of the patient. This will be the inferior, and then whatever's closest to the transducer first. So this is the anterior portion of the patient, and then the bottom of the image is going to be the posterior portion. So as you can see here, this sagittal scan is taking images, from the right and left side here. Then you've got the transverse scan. So same thing, we're going to make sure that that transducer marking is pointing towards the patient's right side. So then the right side of the image is going to be here, left side here, and then still the transducer is closest to the anterior portion of the body, and then the bottom of the image is going to be the posterior portion of the body. A coronal or a lateral scan, so this is the left lateral portion of the patient. They're coming in from the side, but again, we're making sure that transducer mark indicator is still pointing towards the patient's head. So this will be the superior portion of the body, inferior portion of the body. But this now, because the transducer is closest to the lateral side of the skin, the top portion of our image is going to be the lateral, and the bottom portion is going to be the medial part of the body. So that's why it's always so important to make sure that the mark on the transducer is in the proper position from the start, so that you are able to visualize the anatomy the best you can, and there's no confusion. So the pertinence to the medical community for sonography is it's quick, it's non-invasive, unless you're having a transvaginal or a rectal ultrasound. It's portable. We can take it to the patient's room. We can move around the hospital with it. It's relatively inexpensive. It is more expensive than general radiography, but it's still relatively cheap, especially when compared to things like surgery. And it's also a safer option because there is not radiation involved. Remember, ultrasound uses sound waves, so there is no radiation. So ultrasound cannot penetrate air or bone. So those are things that are not going to be very good to visualize on ultrasound. Air and bone just look white, So it's very hard to see those things. So we usually don't use ultrasound to look at bone or anything that has air filled, like the lungs. So that's why ultrasound is not good at visualizing the lungs or bowel, because both of those are filled with air. Bone is just white and they can't penetrate the bone, so anything that lies underneath a bone is very hard to visualize as well. Ultrasound is really good at visualizing soft tissue, organs, or fluid-filled space. So remember, fluid is black on ultrasound, but soft tissue and organs, they are a varying scale of gray. The more dense the tissue is, the brighter white it's going to look. So a poor quality image is due to beam distortion from overlying fatty tissue. So if you do have a patient that has more adipose tissue or fat, it is going to be a little bit harder to visualize, so your image might be a little more poor quality. So again, like I said, ultrasound provides evaluation of abdominal organs, so we can look at the kidneys, liver, pancreas, gallbladder. We can see those structures really well. Cardiovascular structures, heart, and the carotid artery. We'll get into the heart more when we talk about cardiovascular ultrasound in a few weeks. Sonography is also good at visualizing the pelvic organs and a fetus. We also use it to look at the breast, thyroid, scrotum, and prostate. Ultrasound is also good at looking at the eyes. So we can see if there's anything going on there. And it also shows blood vessels and Doppler, which is the flow of blood. Patient technical components. So again, patient characteristics. Patients can be large or small. They come in all shapes and sizes, right? So it is going to be easier to visualize most anatomy on a patient who is smaller. The more adipose tissue a patient has, the harder it is to visualize things, and the less detail and quality of images that you have. Pathology is going to affect some things. I mean, if patients are in pain, if they have things going on, it's going to make it a little bit harder to image. So what patients should expect from exams? They're overall fairly simple. The patient might have to change. There is some prep, and we'll break that down just a little bit. But if the patient preps, that's prior to the exam. When they come into the hospital, they may have to put a gown on, they may have to change. It's going to depend on where you're scanning. Carotid, heart, things like that, you're going to have to change and put a gown on. Sometimes abdominal ultrasounds, you can just lower your pants a little bit, move your shirt, things like that. But it's going to be dependent on the hospital, the technologist, and what you're doing. Positioning is a little bit easier as far as patients. They need to be lying down most of the time on the stretcher. They can lie on their back or on their side. We might have them move from their back to their side just a little bit to be able to position a little bit better to get the transducer in the area or region of interest. The transducer does have to come in contact with the skin. You have to use the gel, so that can make a difference whether it's cold or warm, and how that feels during the exam. After the technologist goes through and scans the anatomy, then the patient just has to wipe off the gel and get dressed. Sometimes the technologist will go and talk to the radiologist prior to the patient leaving, but if they don't, what happens is the patient will just get dressed, leave the department. After the sonographer is all done with their images, they'll send them off to the radiologist, and the radiologist is going to go through and dictate those images and send a final report to the doctor. So overall, it's a very simple process. Just like all the rest of them, like I said, there can be fear, anxiety associated with these exams because the patients don't know what's going on, and they might be worried that, is it cancer? Is there something serious? Am I okay? So there could be a lot of fear and anxiety. The most frequent exams for sonography are going to be abdominal, pelvic or obstetric, or OB for the fetus, and the carotid artery in the neck. Those are the 4 most frequent exams in sonography. For obstetric or OB ultrasound to look at the fetus, what we're doing is we're checking the development of the fetus and looking for any abnormalities. So prenatal ultrasound can be used for a lot of the following things. So one, to determine the age of the pregnancy. Sometimes it's not exactly clear when conception happened, so they can go off the date of the last menstrual period, but it's not exact science. So they might want to go through, verify the age of the pregnancy. A lot of women, their due dates have changed based on the ultrasound. They thought they were either further along or not as far along, and that changed it. They're also checking to see the number of babies. Is there only one? Is there two, three, four? So that's what they're going to look for in that. They're also going to examine the baby's physical development. They're going to check for a heartbeat and see if it's regular or irregular. They're also going to measure the amniotic fluid, especially later in the pregnancy, to make sure that there's still enough amniotic fluid for the baby to make it to term. They're going to image limbs, spinal column. They're going to check on the development of the brain and other organs. So they're going to do measurements on those limbs. They're going to look for the spinal column to see if there's any abnormalities like spina bifida. They're going to check the development of the brain again to make sure that there isn't any fluid or anything like that, any abnormalities that could cause issues with the fetus. They're going to look for any other birth defects, missing limbs, cleft lip. They might also use ultrasound as a guide to do the amniocentesis, which is a test that they'll do where they put a needle in to take some of the fluid off so that they can test to see what's going on. They can tell the sex of the baby, they can see if there's different diseases present, and they also might use ultrasound as a guide for that prenatal surgery. There are times when surgery is performed on a fetus while it's still in the womb. So that they would use that ultrasound guided at that point to make sure that that doesn't injure the baby. Now, preparations for some of the different procedures, or different scans, I guess I should say, not really procedures. But an abdomen, the prep is NPO for 8 hours prior. So nothing per mouth for 8 hours prior to the scan. We want to make sure that the GI tract is empty when we're looking at the abdomen. And it also will help distend the biliary tract. So we want to make sure that there's no food in there, that it's not causing the gallbladder to contract from eating previously, and things like that. Pelvis and obstetrics are the exact same. For both of them, you're going to have the patient drink 32 ounces of water 1 hour prior to the scan. What that does is it helps fill up that bladder, which will help provide an acoustic window. So when the bladder's full, the pelvic organs are easier to visualize. What it does is it moves the uterus up and it pushes the bowel away. So it'll make the uterus a little bit flatter, which is easier for those sound waves to bounce off of. So it's really important to make sure that that patient has drank the 32 ounces of water. If it's not full enough, when they get there, you can scan them, you can see that, and then you can have them drink more. It is very hard. Be aware of your patient's comfort. There have been times, I've had a lot of ultrasounds in my life, so I have 3 pregnancies, but, there are times where my bladder is so full, I am in excruciating pain waiting. There's been times where I was waiting 45 minutes past my scan time, and I couldn't hold it anymore. So these are things that you need to consider and think about as a technologist, is your patient's comfort as well. I had to go to the bathroom at one point when the scan was 45 minutes behind, when they hadn't came out and I couldn't take it anymore. And you have to realize that every patient's going to be different too. So even when you're pushing on them when their bladder's full, it may be very uncomfortable and painful for them. Vascular and small parts, such as carotid, testicles, they do not require any prep at all. So things that require no prep would be a carotid, a renal ultrasound, kidneys, or testicles. Those things are ones that would not. Thyroid. No prep. Oh, I guess I could have waited till this page. So extremities, thyroid, renal or kidney, cardiac, and chest, those do not require any prep whatsoever. Side effects, there's really none. We don't use radiation, there's sound waves, so they have not, they've been using ultrasound for, you know, over 30 years, and they haven't found any side effects from it yet. Oh, way more than 30 years. My math skills are off, sorry. Patient perspective for ultrasound. Most patients feel like it's pretty routine. It's easy. There is the modesty issue, especially when we're looking at cardiac ultrasound. If you've ever had a cardiac ultrasound or known someone that has, I mean, they're looking right at your breast tissue, so that is exposed during the procedure. So try to do the best you can to give your patients modesty. Pelvic or OB, they can experience bladder discomfort, like I said, can be very uncomfortable for those patients. So keep that in mind when you're scanning them. Emergency situations, again, a modesty issue. Like I said, there's times we have to cut the clothes off the patient, so we're going to have to make sure everything's out of the way. And in emergent situations, we are less likely to be concerned about modesty. We're more concerned about saving that patient's life at that moment in time. The patient can have a lot of anxiety and be worried or nervous, which can come out as anger. So again, remember, don't take that personally. Instead of giving time for that bladder to fill, it takes a little bit of time. Remember, for the prep, they have to drink 32 ounces of water 1 hour prior to the scan time. Well, we don't have time to wait an hour for that bladder to fill in emergency situations. So a lot of times what they do is they have a Foley catheter put in place, and they manually fill the bladder up to eliminate that wait time so that we can scan the patient quicker. The other thing that I guess I want to go back and touch on is the patient's perspective a little bit, and give you a little more personal info and a perspective from a patient. Now, when you're working with OB ultrasound, it's a little bit different. There's a lot of emotion involved in that. Not to say there isn't emotion involved in the rest of them, but with OB, there tends to be a lot more emotion. I was actually pregnant, and I had a scan that was unofficial, but the tech had a very hard time finding the heartbeat, and she saw a black pocket around, and she thought, that could possibly be blood. So she told me if I started to bleed that I needed to go in to have a scan. So it wasn't even then a few days of that unofficial scan that I started to bleed. So I called my OB doctor, and they told me to go into the hospital and get an ultrasound. Now, I know that the technologist was aware of the reason that I was there. I'm sure it was listed as possible miscarriage. And when the technologist brought me in, she laid me down on the table and started scanning, and she did not say a word to me the entire time. And I knew she knew that the baby didn't have a heartbeat. I knew that the baby didn't have a heartbeat. But it was such a different situation. I don't know what the right thing to do in that situation is. I mean, if she would have talked to me like, oh, how's the weather? I could have been like, really? She's talking to me about the weather when I could be losing my baby? And when she didn't talk to me, it was a clear indication that something was going wrong. So even if I hadn't known at that point, I would have known by her behavior. So I've thought a lot about it, and I feel like the right thing to do in a situation like that is to at least explain to the patient what you're doing. I'm just going to get some scans for the doctor. I'm going to try to take some measurements. You can give them very basic information without saying things like, all right, I'm going to look for a heartbeat, and then you can't find the heartbeat. You don't need to do things like that. But there needs to be a happy medium, to give your patient that good quality care and to make them, not feel so alone or upset. Because sitting in that room, knowing something's wrong with your baby or could be wrong, and then the sonographer's not even speaking to you, and then leaves you in there by yourself, that's hard. That's uncomfortable. It's not a good feeling. Like I said, but going to an extreme and, hey, how are you today? Well, obviously I'm not good. Oh, how's the weather? I don't really care about the weather. There's got to be an in-between, and I think the best solution to that, personally, is just being fairly technical. I'm just going to get a few scans here so I can show them to the doctor and letting him know what you're going to do. All right, I have everything that I need. I'm going to go show these to the doctor, and then I'll be back in to talk to you. Just those little things can make a big difference. Talking to your patients, helping relieve some of that anxiety or discomfort. That's part of your job too. So the cost of an ultrasound is relatively, again, inexpensive as far as medical costs go. So the cost of like a renal or kidney ultrasound could be about $450 to a complete fetal survey being around $800. Now, those are not exact numbers. Every place is going to be slightly different, and the cost might be changed. Contraindications, or things that would interfere with an ultrasound exam. So if you're having an abdomen or pelvic exam, you cannot have an ultrasound done after the patient has had an upper GI, a contrast CT, or a BE scan. Do you guys remember why? So all three of those exams have contrast in them in the abdominal region, right? So the upper GI, there's going to be contrast in the stomach, and then it's going to go through to the small intestines. The CT, it's going to be all throughout the intestines. And the BE, same thing. It's going to come rectally, and it's going to be all throughout the large intestine. So if we're looking at organs in the abdomen or pelvis, the contrast is going to obscure that, and we won't be able to see anything. So the patient can have these exams on the same day. The ultrasound just has to be scheduled first before the contrast is put in. That way they can scan them free and clear of any contrast. Then the patient can go on to have their contrast studies and everything will be fine. So who performs an ultrasound? A registered diagnostic medical sonographer who is registered through the RDMS. So what they do is they're going to go through an accredited associate's or bachelor's degree program. They're going to have at least 1 year of clinicals with didactic courses, and they also have 1 year of college core curriculum prior to their 1 year of clinicals. So a lot of people think that sonography is just a 1 year program. The program itself is 1 year, but it's still going to take 2 years to complete that program because you have your core curriculum that you take prior to the admission to the program. So once you do your clinicals and take your didactic courses and do your core curriculum, you have to pass the national board exam. The national board exam is done through the ARDMS, which stands for American Registry of Diagnostic Medical Sonographers. So make sure that you know sonographers are registered through the ARDMS. So after that person passes their registry exam, their initials would be, after their name, they would put RDMS for Registered Diagnostic Medical Sonographer. Technologist perspective, obviously every technologist is going to have a little bit different perspective, but most of them, it's either routine, it's exciting, it can be grotesque, it's hard to deal with people sometimes, and it can be depressing. If something's wrong with an individual or something's wrong with their baby, that can be very depressing for somebody. But it can be exciting too. I mean, think about the person who's been trying and trying to have a baby and they finally get pregnant. How exciting is that, sonogram with them? How exciting is it to find out the sex of a baby? Now, obviously, OB is only one small part of it. There's a lot of other things that are going on with ultrasound, but those are some of the different perspectives. Again, it can be risky. The patient could have hepatitis, HIV, or AIDS. Anytime we're dealing with patients, the possible risk of exposure to these diseases is there, so we just need to always take precautions and use personal protective equipment if necessary. There is a high risk for musculoskeletal injuries. So sonographers do have a high risk of MSIs. So studies actually show that 84% of ultrasound professionals have experienced some degree of pain related to their profession. So 1 in 5 sonographers sustain a career-ending injury. So ergonomics is really important in sonography. Ergonomics is the science of proper body mechanics, postural alignment, and workspace design. So if you think about how you're scanning your patient, if you're not using proper body mechanics and you're leaning too far or reaching too far, it's going to cause you injury. You can also have scanning injuries in your wrist. So a lot of technologists, ultrasound technologists, can have back issues, neck issues, shoulder issues, and carpal tunnel issues. So it's really important to use proper ergonomics when you're scanning patients. The future of the modality, they have listed 3D ultrasound. 3D ultrasound's already here. 4D ultrasound, HD ultrasound, panoramic views are new, and then also wireless transducers. So wireless transducers obviously don't have the wire that's going to connect to the machine. So the nice thing about that is it gives you a little bit more range. The downfall to them is they get lost. You set them down next to the patient, forget about them. They also need to be charged, so it runs the risk of the battery dying and things like that. And then also digital is not the future, it is here right now. Career advancements, you could become a manager, a lead technologist, you can work in sales, applications, education. And also one of the things that doesn't really mention is here is an entrepreneur. There is actually a place in Jackson called First Glimpse where you can go in. This lady owns her own business and she is a sonographer and she does fetal scanning. She does 3D, 4D, things like that. So she has a lot of other things in there too. She sells stuff for gender reveal and baby clothes and items and stuff like that. So that's just another thought process of a career advancement or something you could do with sonography. Compensation is going to depend on your experience, your credentials, where you're located. Like I said before, sonographers in Michigan are going to make less than sonographers in New York or California. The median wage for sonography is about $30 an hour, give or take. I'm sure there's many sonographers that make more than that and some that make less. The other thing with sonography is there may be on-call pay. Some hospitals do not offer 24-hour care for sonography. So what happens is usually they do a first and second shift, and then third shift is on an on-call basis. So there's a technologist that will be on call, and they'll be expected to be at the hospital within a certain amount of time to scan emergency patients. So you get a base pay while you're on call, usually a few dollars an hour to carry the phone or pager, and then once you come into the hospital, you'll get pay dependent on the hospital. Some do as soon as you punch in, you get 2 hours of pay no matter how long you're there. Some of them it's time and a half, some of them it's double time. It's all just going to depend on the institution. You're also going to get medical benefits, healthcare, optical, dental, all that. Ethical issues with sonography. There's actually a bigger ethical issue, which is scanning for entertainment. That's the biggest no-no when it comes to sonography. There should be a medical reason why we are scanning a patient. It shouldn't just be for fun. The other ethical issue is unqualified people performing sonography. Physicians will do it, medical assistants, nurses, obstetricians, gynecologists, or unregistered technologists. They just don't have the same training as a sonographer who's gone through a program. So they might be able to do the basics, but you're not going to get as good a quality of an image as you would with the sonographer doing it. Liability is also an issue with sonography. So ultrasound is operator dependent, okay? The person scanning is going to determine the quality of the study, the image, the anatomy that's being imaged. So what happens is sonographers write preliminary report for the radiologist. They scan the patient, they get all their images, and then they write a preliminary report. So the radiologist could actually take that preliminary report and use it as their final report without actually viewing the images. Now, that should be on the radiologist, that's up to them. But the problem is that if a sonographer misses the anatomy, it's missed. You can't get it back, right? Because you're scanning and recording. So if you didn't visualize something in that scan, it's missed. That's kind of the difference that comes from radiology and sonography is in radiology, we take an image and we include all the anatomy in that image. So if something's missed, that's on the radiologist because we included it in the image, so it's there. It's easier to make sure that everything's 100% included. We can't share any information with the patient. We tell the patient, oh, the radiologist is going to read it, and we go about our business. With ultrasound, if they don't scan or record an area of interest, then it's missed. The radiologist can't go back and look at it later unless the patient's called back and rescanned. The other thing is the ultrasound tech has a lot more leeway with relaying information to the patient, especially in OB ultrasound. They can sit and go through the scan with the patient and be like, okay, well, here's your baby. This is, this is a girl. Here's the girl parts. This is the head. This is their lips. They can go through and explain everything. So they have a lot more ability to talk to the patient about the images that they're seeing. But what happens is that can open up the sonographer to lawsuits, especially if a patient is misdiagnosed. Most of the time, that's not going to fall 100% on the sonographer. When you're working for an institution, they carry liability insurance on you. So your hospital or organization should protect you in those situations. As long as you're working within your scope of practice and not doing things that you aren't supposed to do, your institution will protect you. So for further information about sonography, then you can check out some of these sites. I'm going to end this slide here and then I'll start a new one for the images so that they're separate and not as long.